Sure, I'd be glad to. Thank you. I was hoping we could talk about treatment, too, and all of this as well, so thanks for the segue, Joe. What Joe is referring to is, and by the way, in Shenango County, we have a county-operated outpatient clinic that serves individuals who have chemical dependency needs. That clinic is now co-located with our outpatient mental health clinic, so we're actually positioned to better serve individuals who really need services from both clinics. But we're a county-operated clinic. We're the only OASIS and OMH licensed outpatient clinic in a small rural county. The first thing I would say that we struggle with is relative to the regulations that we're faced with in order to deliver services. And I have to admit to you today, I'm a clinician, but on a day-to-day basis, I'm not actually doing the work that I'm asking my clinical staff to carry out. And when I stop and listen to what is required by OASIS in terms of the Part 82 outpatient clinic regulations, what's required by Medicaid, what's required by our commercial insurance products, what's required by managed care organizations, just to be able to get people the level of care that they need, the amount of care that they need, it makes my head hurt. And I just keep thinking there's got to be a more efficient, effective way to do this. I have people lined up and ready, willing, trained experts who want to help people. And we have to think like criminals sometimes to try to figure out how to maneuver all that's in front of us in order to get the services that those individuals need. It comes down to, and the heroin epidemic has really blown this out of the water because we have to act fast. People's lives are on the line. With other drug addictions, we had some time. We could usually, we weren't looking at life and death situations. This is different, this heroin epidemic. And so it comes down to access. It comes down to timely access. It comes down to being able to move people to the level of care of treatment they need. There have been some improvements recently with the new locator tool that OASIS has given us. It's provided us a common language so that when we're on the phone talking with another provider on the other part of the state, we're speaking the same language. So there are some small improvements, but if I can ask anything, I would ask that our state agency that regulates these outpatient programs, I would just ask that they be willing to come to the table and really look at what is getting in the way of actually helping people. So regulatory relief. We run into it with our prevention programs as well. We are really very limited into what we can do, and we need prevention. And I don't believe that it should just be OASIS doing prevention. I think it was mentioned earlier, this needs to be a collective impact. I really believe that. I think we as a community need to start talking about prevention in primary care, pediatric sites. I think we need to be talking with parents prenatally talking about prevention. That message needs to follow in through the schools and all of the medical community and throughout all of the community itself. The faith community certainly has a role in that, but that message needs to be delivered throughout. And we're really talking about changing social norms, and that takes time, and that also takes a collective impact. So regulatory relief, and we've talked a little bit about the forensic services, or what I refer to as forensic, those services in the jail. I believe we are missing many opportunities at that stage, and I'll describe it sometimes as a come to Jesus moment. Sometimes, they're in jail and they realize they need to change their lives and there's some level of motivation. That is the time we need to take every opportunity to engage individuals. We've started in Shenango County to do what we're calling transitional supports, working with our sheriff, and where we have a case manager type position and a peer advocate, someone who's been there, done that, and is in recovery. They team up and they engage an individual before they leave the county jail, and they really come up with what's the plan. And it might be how to access treatment, but it might also be where you're going to live and how you're going to support yourself and what's the plan to apply for Medicaid. So all of that gets worked on before the individual actually walks out of the county jail. So we just started doing that in January, and I'm hoping that will help in some of the, round door, turning door that we see often with particularly this young population. But you have to understand, again, almost 80% of the individuals currently sitting in the county jail have some history of substance use or abuse in their story, and a lot of that is based on self-report, so the number might actually be higher. Our state agency, OASIS, gives us no dollars, no funding for those services in the jail. I do that work in the jail with my OMH dollars. I also have a full-time forensic person that's in the jail. I'm using those OMH dollars to provide services for this 80+% of individuals who have substance abuse needs or substance abuse treatment needs who are currently in the county jail. So I think it's time for OASIS to wake up and say, we need to look at this opportunity and also, put some money behind it, because I look at the forensic population as an area where there's great opportunity. And let me also say, we talked about the stigma. Oftentimes in these communities, this group of people is considered by the public as the least deserving. You've got individuals who are addicts. They've got a history of criminal behavior. They're in the county jail, or they've been in and out of the county jail. And it's difficult for the public to see them as deserving any help or services, and we got to turn that around too. And I think one way to turn it around is to get our own New York State agency to recognize this is a valuable opportunity.
Pretty amazing. It was part of the budget negotiation process in the Mental Hygiene Budget Subcommittee, and to talk to the commissioners and ask specific questions about funding, they would argue that we have plenty of money and, we don't need additional money, but we all know that that's not true. So, my love is for law enforcement, but can we stay on the treatment piece and then we'll move to law enforcement? I think that would make the most sense. So, Carmela, do you want to weigh in on what you're doing and your agency is doing? I'll ask Alan and to weigh in as well, and then Dr. Nichols will come down to you in the program that you're involved in Tioga County, and then we'll come back to law enforcement.
I would just totally echo that there are some real regulatory barriers that do not allow us to provide services the way that we need to. And the heroin epidemic is just a huge game changer. Sometimes we will have clients even with lots of treatment, lots of support, and they're extremely difficult to help them stabilize. So even, the day after they successfully complete their long-term treatment, after the inpatient, after, 9 months of outpatient, we'll see a relapse. So it's very, very hard to stabilize. So I think we do need more research to figure out what actually is really, really going to help. Because, even sometimes with lots of services, people are just really struggling. From 1997 to 2008, I worked in Baltimore. And if you watch Drugs, Inc., supposedly Baltimore is the heroin capital of the country. But, in that space, in the city of Baltimore, we had 5 outpatient detoxes. We haven't had a detox here since 2010. So ACBC in November, one of my colleagues that I used to work with in Baltimore pretty much gave me everything, all the protocols, and we're ready. We're ready to start some demolition and kind of prepare the space. I've been working with my landlord. We have the floor plans. So we're looking for startup, and that's not a silver bullet, but it might be a buckshot. If we can get 10 people a week properly detoxed so that they will actually feel okay to do some treatment, inpatient or outpatient or whatever, I think it would help. Because we see a lot of people, maybe 10 to 15 a week, that they're not going to make that referral to Conifer Park. We're not going to get them that bed at Syracuse Behavioral Health. They're not medicated at the ACC. So, we can put forth our very best effort to provide them timely access, and they're not going to make it. You know, it's just not going to help stabilize them. And I also will echo Ruth's sentiment about the collective impact model. Like, I think we're at this point where we've communicated a lot, we've done a lot of forums, but we need a framework, we need a structure, and we need a plan. Because literally, like, last night I got my kid and drove her to ACBC to the clinic because my janitor found needles in the bathroom, you know, and I can't let somebody come in the morning and, like, you know, it's just there, you know, like it's every day we're literally just putting out fires, putting out the next fire, and, you know, just not seeing people stabilize the way that we want to, even with being in treatment. And also, you know, like, the demand has increased so much, you know, like, there's not enough room anymore. You know, like, we would expand services, but where? You know, like, you run out of space. You know, I've got vacant positions and I don't have an office for people. You know, like, it's hard to co-locate clinicians in an office because obviously you need some privacy. You can't have 2 clients and 2 counselors, you know, in a room at the same time. So, yeah, and I think the state, like, they need to come to Jesus. No offense. I'm seriously, the regulations, like, it's bad.
We will, my staff and I will circle back with the treatment providers and talk specifically about the regulatory reform that needs to happen, and then I'll communicate that to the co-chairs of the task force, and hopefully we can you know, put pen to paper and help with that. And one thing I've learned in Albany is that there's a great deal of bureaucracy and things. There's a lot of personality in Albany, and there's a ton of bureaucracy, and things don't move nearly as fast. But I want you to know that I'm advocating very strongly and as hard as I can to get you that startup money that you need to expand your services. So I'm working diligently on that. And if I had my way, we would have the money today. But again, there's just so much bureaucracy, it doesn't happen that quick. So we're working on that. Dr. Nichols, can you speak to your program and Mr. Schechter?
Yes, thank you. I'm humbled to be up here with all these people, particularly with people who've lost children and other loved ones to the problem. I feel I'm not up to the level of commitment and loss that they've gone through, but in any case, to treat this problem, because I'm one of the people that treats it, requires a comprehensive biological, psychological, and social approach to the drug addiction and to the related but very distinct problem of chronic pain management, which is actually in many ways even more challenging, medically speaking. And I think that Barry and I have, over the last 10 or so years that we worked in the same office, evolved an efficient and, for the most part, effective approach to the problem. Generally, I try to provide comprehensive primary care services to anyone that we're treating with Suboxone, Vivitrol, or any other medical treatment for addiction, and similarly with chronic pain management. And there are a lot of challenges. We're very busy, but it's not really particularly lucrative. That's one. I think by virtue of my training, I'm very well qualified to undertake this medical and psychological treatment approach. And I think that family medicine doctors in general are the best people to do it because, frankly, psychiatrists often don't have the biological medical background to feel comfortable using a lot of the powerful drugs that are required, in opiates and so forth. And unfortunately, I see very little, if any, support for family practitioners in this area to pursue this treatment. Very little support coming from the healthcare institutions that dominate the healthcare in the area. I think iStop is good. That's where you have to check on the computer to see if somebody's doctor shopping and so forth. But we've been pilloried for little technical glitches and so forth by iStop personnel. That's anxiety producing and upsetting, but I understand. DEA's been in the office looking over the records, fine, no problems. But again, it doesn't happen with any other part of my practice that you got the guys with the suits in there looking over things page by page and asking all sorts of questions. Insurances are not helpful in the least. The opposite, to try to get them to pay for drug testing and urine drug screens and everything is just a constant fight, frustrating. The transition of the patients between different levels of care is terrible. If they need higher levels of care, we have to basically plead and cry and spend hours begging people to take them and getting the insurances to pay for it. Just really frustrating. But anyway, our system works. I actually like it. It may sound like I don't with all these complaints, but we get along well, and I think we do a good job, and I think it could be a model for other family doctors to do it, if they're interested. Family practitioners are perfectly trained to do this, or family nurse practitioners also. They have the psychiatric and the medical training that you need to do this, especially chronic pain management. Pain management doctors aren't necessarily set up to do addiction treatment. Well, anyway.
Hey, Doctor, let me just weigh in here just a moment. After speaking with you and gleaning some information at Senator Seward's heroin roundtable, I authored a letter to United States Senator Charles Schumer and Kirsten Gillibrand in an effort to get them to move on the TREAT Act, which would allow others to participate in the prescribing of Suboxone, and we urge them to move on that, to make it
non-physicians.
Yep, to make it more readily available. So
good idea.
I think
that would really help.
Yeah, and again, we gleaned that from our conversation that you and I had, and hearing from another doctor in Oneonta. So we're hopeful that there will be some movement on that. But again, I think there's even more bureaucracy in Washington than there is Albany.
Oh, good. I appreciate that.
Go ahead,
maybe Barry.
Barry, thank you. Yeah, please.
Thank you. Thank you very much. I wrote some notes. First comment, when Senator Ort introduced himself, the words that I heard, treatment on demand, they just go to my core, because that's probably the best thing that could happen. It doesn't exist right now. I wrote some notes so that I didn't go too tangential. So the first thing I wrote was, what are the roadblocks to treatment and recovery? And the first thing I thought of was stigma. And that's what I've heard us talk about here. How can we normalize treatment? I see people every day, many people, that have addiction problems. I have a list right now, probably for our office in Tioga County, 120 people waiting for care. Why is that? Why is that? Well, because Dr. Nichols can only prescribe medicine for 100 people. That's the law. Now, there's no such law for how many patients can get prescribed opiates or opioids. Every primary care doctor that has a DEA number can do that. But not every doctor who has a DEA number can prescribe buprenorphine, nor, going along with stigma, do they want to. Because let's be very clear. My patients tell me, I'm talking about people that have been stable 10 years, grandfathers, people with positive, good careers, that when they go to the pharmacy and they get a prescription for Suboxone, pharmacy tech might look at them and roll their eyes. What do you think that makes a person feel like? That actually has a good life. I just needed to say that. But I think that if we could somehow normalize treatment, take the fear of criminality out of addiction. I understand we've got all the law enforcement people. What I'm saying is for a person that's addicted to opiates, by their very existence, they're committing a criminal act. That makes them at risk to be incarcerated. That means not having their drug. That means withdrawal. That means more anxiety. That means more use of drug. It's a very vicious cycle. How can we do that? I think we could, if we treated it like any other healthcare issue, if we utilized medication counseling, peer counseling, I made a note, the ICRC, which regulates CASACs, now has a credential for peer counseling, okay? It's frankly not as rigorous as a CASAC, but it's what people need. People don't always believe what I say as a professional. I look, at least on the surface, I look better to some of my patients. But they do listen to other people that are going through this recovery process. And I think that's essential if we could get into that. NADAC, another national organization, and the National Alliance of Methadone Advocates, NAMA, also offer peer credentials. I think that we need to close the loop that's going on. When I send someone to the Addiction Crisis Center, and I discussed this with Art Johnson, when somebody goes to the ACC and they have opiate addiction, heroin addiction, they're probably not going to stay more than a day because the next day they're in withdrawal and they just leave. They have to leave. Could we not, and I was pleasantly surprised, that loop might be closed. We can prescribe Suboxone at places like ACC. After a thorough biopsychosocial evaluation is completed, I'll go even one step further. Perhaps we could use that in the jail. Wouldn't it make, person is in jail. I get it, they're in jail. But isn't it a burden on the sheriff's department, on the medical staff to treat people, somehow keep them there while they're going through withdrawal? Think about that. I think we could do it. I think we can make strides together. This is a wonderful group. Thank you for letting me be here.
Thank you, Barry. Luann, can you speak about your program from your faith-based perspective?
Yes.
And then we're going to move on to law enforcement.
Thank you, Senator, for asking me to be on this panel. I don't take it lightly. 5 years ago, I began ministering in Broome County Jail, specifically to the women. And my eyes were opened very quickly that I'm glad somebody said that it was 80%. I felt like it was 99% heroin addiction in there. And the reason they were there, I've seen the spectrum of 3 generational drug addicts actually in there one time, and one of them was pregnant, so there was 4 generations of this family in there. And then I've seen college graduates. I've seen women that had 1 semester away from her degree at Penn State, and her life was gone and done because of heroin. I conduct chapel services for them, and I came across the revolving door, and I said, this ought not to be. I had a parent of one of the girls say to her, this is the poor man's rehab. And I thought to myself, if this is a rehab, I need to make a difference in here. So I started doing non-contact visits with each of these women, trying to get them to think right thoughts, make right choices. And so then I was able to do once a week, the door open for me to do classes on recovery every Tuesday. And I will give them weekly homework. And let me tell you, they love it. They love getting their homework. They love doing it. But I'm only allowed a half an hour out of 7 days a week to do that class time. Then I began one-on-one mentoring. And at this point, Broome County Jail has been so cooperative with me. I'm able to go right into the pods, sit down with a girl one-on-one, and we talk. And it's a coaching. I'm coaching them in their mind, spirit, and body. So I saw that there was the revolving door, and I wanted to make a difference on that. So my second goal was an exit interview. And what I do is I sit down with the girls and I say, where are you going to live? What kind of recovery do you need? And what church do you think you're going to go to when you leave here? And I now have a team of 12 women who are volunteers who will, at a phone call, pick up those girls, take them for coffee, take them to a meeting, and just encourage them. And there's some meetings, faith-based meetings in this community, Free in Christ, Celebrate Recovery, and Brand New. And I will pick up a girl, we will pick up girls, and take them to the meetings. I am seeing success. After 5 years, I have girls, women that have completed their GEDs, working towards their college degrees. They're successful in the workplace, and most importantly, I'm seeing restorations of families. Moving forward, I would love to have more class time in there. Ruth, you've got the answer. We've got to spend more time inside there. And I didn't see Barry. Yes, Broome County Jail is the poor man's rehab. Let's make it a good one. I'm willing to do it. I volunteer my time. I have 12 members that volunteer inside and out. We want to see heart changes from the inside out, and we need to help them on the inside and out. We need to stop the revolving door. We need to stop the deaths. And it is my vision to be successful in this program. This is such a complex issue. This is my piece of the issue that I'm willing to go to bat for these women. And ultimately, I'm going to start a program for the men. So thank you for having me here. It's been very enlightening.
Luann, thank you. I think you're very inspirational. I think it's important moving forward that we keep faith-based leaders on the forefront of this issue, and we do a better job as a community of ensuring that faith-based leaders are part of the conversation that we have.
Thank you.
You're welcome. Changing gears a little bit, DA Cornwell, can you maybe just speak about the things that you're seeing, the program that you're running, and then your involvement with Judge Palella, and we'll segue into drug court in Broome County and how you've expanded that program.
Sure, great, thank you. We've taken a perspective that it's over.
Good, you can slide right.
There's a supply side component and a demand side component. The supply side component are the drug dealers and the suppliers, and the demand side are the users. So we've made that very clear. On the supply side, I haven't given up on the supply side. I know we can't arrest our way out of the problem, but I can arrest enough people to clean up Broome County. That is my goal. So we have increased we have 3 times as many indictments this year for drug dealers as we did last year. We don't plea bargain with drug dealers. They have to plead the charge or go to the judge and ask for a sentence, or they can go to trial. So that's how we've been very aggressive. We're being smarter about it and not harder. We've created an intelligence-based system with the help of all of our local police chiefs and the sheriff and the National Guard to come in and help really put our finger on who the targets are, the people we want to go after, and we're going to make their life as miserable as possible. Go after them at DSS, go after if they're cheating on welfare, which a lot of them are. Go after them in family court, go after them, any way we can to make their lives as miserable as possible. That's my goal, to make it as uncomfortable in Broome County for drug dealers as I can. It includes working with authorities in New York City. So that's the supply side, the aggressive DA side, that prosecution that I think we have to do and recommit to that. And we're seeing it results right away, moving cases quickly into indictment and prosecuting them very aggressively. As you can tell, I don't mince words. It's what I plan on doing, and the drug dealers are starting to get that message. On the demand side, there are two types of demand side cases. You have people that are charged with crimes and people that aren't charged with crimes. If they're charged with crimes and they're not violent crimes or sex offender crimes, things of that nature, we are referring them to drug treatment court to Judge Palella, and we've increased the incentives so people shouldn't be stigmatized with a felony for the rest of their lives. If they complete drug court and they stay clean, felony should be gone off their record. If they're misdemeanor crimes, they should get in, and we need to catch them early. It wasn't always the case. Now I've expanded that, catch them early with misdemeanor cases, wipe out their record, their misdemeanor record, if they succeed. There's $1 million of income and difference if somebody that has a criminal record as an 18-year-old versus no criminal record. They'll lose $1 million over the course of their life in income because they're saddled with this record. Well, if they clean up their problem, they take care of things, they get on a straight and narrow, then they don't need a criminal record. We've done our job. We've corrected the behavior, and we don't have to worry about the future crimes and the increasing crimes. I've also, on the demand side, if anybody calls my office and they say that they're a heroin addict and they want to go to treatment, they go to treatment. I could tell you right now, we started our program, Operation Safe, 2 months ago, and I took a lot of grief from other DAs saying, why are you involved in this? This is not the district attorney's job to send people to treatment. It is. Because if people are in treatment and they're off the streets, they're not committing crimes and they're not dying. So we're, saving people's lives. So that's why I've made it a focus. That's how I'll help keep Broome County safe. Our numbers are far above all the neighboring counties. We're in the top 10 in every bad category you could be in. So we're out of 62 counties in New York State. We have the highest number of property crimes because drug addicts steal to feed their addiction. We're second highest in overall crime rate, 9th in violent crimes, and 10th in drugs. And these include New York City, the 5 counties in New York City. So out of 62 counties, we're in the top 10 and everything. And it's not the good top 10, it's a bad top 10. So I figured, we have to get people off the streets and into treatment, and it's not available in our area. So we send people to treatment. I can tell you the last update we had was we sent, in 2 months, 70 people were placed in treatment facilities. And that's no cost to taxpayers. And what we do is do it the old-fashioned way. People come in, they want help. We pick up the phone and we call people. And there are beds in New York State. There are beds every day available in New York State. Not many, but they're available. And the website that the state has, it doesn't work. It's not accurate. It's a joke, to be perfectly honest with you. It was a press conference website. It doesn't work. Our volunteers will call around to all these facilities that said they had 9 beds open, 3 beds open. They're like, no, we haven't had beds open in 2 weeks. So the website doesn't work. If the website worked, it would save hundreds of phone calls for our volunteers calling around to get people in. So if there are beds, we get people in, and we get people in. We're teamed up with some other facilities, and our treatment plan is that they call us, we get them into treatment. We have a doctor that we've going to work with that will provide Suboxone or Vivitrol. Basically, guarantees, not doesn't guarantee, but it's a part of the treatment process to help them to get into treatment, but we get people in treatment between 1 and 15 days. We have 19 people that are going to treatment on the 1st. So we'll go from 70 to plus 19, so long as they hang on that long. But we lose people along the way sometimes because, they go in use, and there really isn't anything available for them immediately, in our area. And so, from my perspective, that's what we've done. But the website's not helpful. It doesn't work. It also doesn't help that in Broome County, you cannot get a drug assessment at the jail unless you want to pay for it yourself. So the fact that 5 years ago we had somebody full-time that worked for the county that did drug assessments, and now we don't have anybody, and we haven't for a long time. Right now there's been nobody at the jail doing drug assessments since October or November of last year. How absurd is that? 80% of the people there at least are drug addicts, and we don't have anybody in the jail to assess them. If they did that, it would be voluntary. They pass that information on to the defense attorney, and I'm not going to speak for all the DAs, but if we have people that have been placed into treatment or started taking Suboxone, and addressing the problem, then let's get them out of jail. I mean, the problem is they're drug addicts. That's why they're committing crimes. We're not talking about dealers now. We're talking about all the addicts. But you can't get somebody assessed. You have to pay. When I was in private practice, we'd have to pay $300, $400, $500 sometimes to get somebody assessed. Normal people can't afford that. And you're paying more on the back end because you're paying for the free attorneys, and you're paying for the jail staff and the overtime. and all that. So really, I mean, it's quite simply, if somebody comes to us and they want treatment, we get them into treatment. And right now, I can tell you we got 100% of the people in treatment. And I didn't want to give out that figure for the first couple months because I knew it would change, so I thought. But we placed 100% of people. Every person that came into my office or called my office and said they want to go to treatment was placed in treatment. So it can be done, but it's been outside of Broome County and outside of New York State. And we have facilities that take people for free because other states are stepping up and doing things far in advance of what New York State is doing. So, you know, you have to hit them hard and be aggressive on the drug dealer side and find people treatment. 80% of my cases are related to heroin. You know, I have 18 assistant district attorneys, and I have 14,000 active cases, criminal cases. 1,700 felonies, and there are 13 of those people prosecute felonies. 80% of our cases are related to heroin, and most of our violent crimes are all related to heroin as well. So obviously the property crimes, but it's the violent crimes, and that's what we've seen. And we've seen our violent crime rate is skyrocketing, and the numbers that will come out soon will be startling. But that's what we're seeing. So from my perspective, hit them hard on the supply side, and then if on the demand side, if they have not been charged, they go into this voluntary program where they'll see a doctor and have the opportunity for Vivitrol or Suboxone, and then they go to treatment. Our minimum facility now that we teamed up with is 90 days. That's the minimum. And we're going to team up with a different facility at 6 months is their minimum. See, when somebody comes in for treatment, it shouldn't be give them a slip, they come back in 2 weeks, then they come back and start outpatient in 2 weeks. If you fail outpatient, then you can get in for a couple weeks. If you fail that, you can get in for a month. If you fail that, you can get in for 3 months. That is absolute, doesn't work. I mean, so how about the first time they come in, they get 6 months of treatment? I mean, those are the numbers we should be talking at. And the facilities we work with have very high success rates because their minimum program's 90 days. But they're telling us they're going to keep people for 18 or 24 months. And then when they come back out, then if it's determined that they need Suboxone when they exit the program or Vivitrol when they exit the program, that's what they do. It helps transition them when they get back home and they're back in the area that they came from. So, I mean, it doesn't seem that difficult to me to mandate that insurance companies pay for a 90-day minimum program the first time somebody has help. I mean, needs help. You're gonna save that money in the long run. I think everybody in the business, so to speak, knows that. So, I mean, that's what we're doing. That's just basically that my